All right, Jared, how are you today?
Good. How are you?
I am great. It's nice to have you here. Thank you for I'm very impressed with us. We're actually a few minutes ahead of schedule, which is great. So, with that, we're excited to have you here today to talk about sexual wellness. With that, I will let you jump in.
Perfect. Give me one moment here to share my screen. All right. Can you see my screen okay?
Yes, can see your screen perfectly. Thank you.
Perfect. All righty. Hello, everyone. My name is Jared. I'm a clinical liaison pharmacist at Strive. I am so excited to be here and to have the opportunity to talk to you all about sexual wellness. A quick disclaimer before we jump in. This presentation is for educational and informational purposes only, is not intended as medical advice, diagnosis, or treatment. These statements have not been evaluated by the U.S. Food and Drug Administration. Compounded medications are prepared for individual patients' needs based on a valid prescription from a licensed healthcare provider. Strive's compounded medications and supplements are not reviewed or approved by the FDA to diagnose, treat, cure, or prevent any disease. The information shared is based on current literature and clinical experience. Individual patient care should always be guided by a qualified healthcare professional. While clinical data exists for FDA-approved commercial products, compounded products are not FDA approved and have not been studied for safety or efficacy. Potential benefits apply to the specific ingredients and may not necessarily apply to a combination of those ingredients. Any experiences or outcomes mentioned do not indicate or guarantee similar outcomes for all patients. Individual experiences and outcomes may vary. Now that we got that out of the way, we'll go over a brief agenda for today. So we'll go over a brief introduction, explore root causes of sexual dysfunction, and then what current care options are available for these patients. Behind every conversation about sexual wellness is a person navigating vulnerability, identity, and the desire to feel whole again. These patients may not always feel comfortable initiating this conversation and might not know what to ask. It's up to us as healthcare professionals to stay informed and provide current, up-to-date information to our patients. So, what are the common sexual wellness concerns that patients are coming in and talking to each and every one of us about, right? When they do things like libido, stamina, erectile challenges, premature ejaculation, vaginal dryness, receptiveness, and even intimacy and bonding concerns are all major concerns that have been addressed to us. So, what is erectile dysfunction, right? Erectile dysfunction is characterized by a recurrent or persistent inability, whether partial or complete, to attain or sustain an erection sufficient for satisfactory sexual intercourse despite appropriate stimulation. Now, there's a common misconception that erectile dysfunction is always a physical limitation or a physical concern. It is not always physical. Erectile dysfunction can happen for a variety of different reasons. Typically, they fall into three main groups, things like physical health, mental or emotional health, and then lifestyle or medication related causes are all major areas for sexual wellness and erectile dysfunction. Physical health impacts may include things like cardiovascular disease, diabetes, hormonal imbalances, and even nerve issues. For mental health struggles like anxiety, depression, stress, past trauma, even relationship problems can lead to ED. And then we take into consideration our lifestyle and medication factors. Lifestyle factors include things like smoking, excessive alcohol consumption, limited mobility, even things like excessive BMIs. And then certain medications and recreational drugs may also negatively impact erectile function. A disruption in any one of these parts, whether it be physical, emotional, hormonal, psychological health, may contribute to erectile dysfunction. And it's important to note, excuse me, it's important to note that psychological factors contribute to anywhere from 10 to 20% of total erectile dysfunction cases and can either be the primary cause or may worsen current underlying disturbances of ED. So, erectile dysfunction is getting younger, but the causes look different. Potential reasons younger men may be experiencing erectile issues, as we previously discussed, include things like stress, performance anxiety, depression, uh, performance expectations, relationship challenges. Physical health also can play a key role in this as well. You see, sexual dysfunction is a very slippery slope. It can lead to further impacts, such as impacts on identity and emotional health. Things like, am I too young for this? Identity challenges around masculinity and being man enough for it, avoidance of dating, and even on the complete, ex, you know, max end of it, social withdrawal. So what are some habits or what are some factors to this, right? So everyday habits, can include things like poor sleep, diet, limited exercise, even frequent pornographic use and recreational drug and alcohol use all can negatively impact sexual performance. Poor sleep, poor sleep quality. So people with sleep apnea or who only experience short sleep, there has been an association with worse sexual arousal and orgasms in women, as well as more sexual dissatisfaction and sexual distress, with poor sleep being tied to it. We want to promote a healthy parasympathetic nervous system. Things like deep, slow breathing, aerobic exercises, better sleep, all help promote a better parasympathetic nervous system, which will enhance the blood flow and help with relaxing smooth muscle. There also can be physiological concerns in term or factors at play, right? Things like a decrease in testosterone or even other hormones with women going through menopause, perimenopause that can result in sexual dysfunction, decrease in libido. Um, and there are studies out there that show that there's been a steady mean decline in men's testosterone over the past few decades. We have medication concerns, things like antidepressants. This shouldn't come to any surprise to any one of us. Things like SSRIs and tranquilizers, serotonin and dopamine, they typically share this inverse relationship where if you increase serotonin, your dopamine release, is inhibited, resulting in sexual dysfunction. For these patients, we typically consider switching to alternatives if it's indicated, things like bupropion or an NDRI, things like mirtazapine, where the risk of sexual dysfunction aspect of the medication is a lot less. In regards to tranquilizers, tranquilizers, sedatives, CNS depressants, all can negatively impact sexual wellness as well through the CNS sedation and other pathways. In regards to excessive pornographic use and expectations. Excessive pornographic use can lead to very unrealistic expectations, and there's actually a condition that's tied to excessive pornographic usage called porn-induced erectile dysfunction, or PIED for short. This is a psychological condition where the brain has become so desensitized to all the sexual stimuli that it's no longer getting the same response, leading to erectile dysfunction. Now, for these patients, I believe the current recommendation is around a 30 to 90-day abstinence to try to get those receptors reset and to be able to have a little bit more of a sexual stimuli to external factors outside of pornographic use. And then we also see, obesity and erectile dysfunction, right? Things like vascular and metabolic concerns and factors. Obesity may lead to erectile dysfunction potentially in a greater extent than even aging. A study has reported that 79% of men presenting with erectile disorders have BMIs of 25 or greater. And a BMI in the range of 25 to 30 is associated with 1.5 times greater risk of sexual dysfunction, and patients in the BMI range of 30 or higher with 3 times greater the risk of sexual dysfunction. We also have to look at the hormonal and neuroendocrine effects that obesity and excessive adipose tissue has on an individual. Inflammatory cytokines released from adipose tissue may negatively impact androgen release. The decrease in testosterone may increase adipose tissue, reduce lean muscle mass, decrease libido, resulting in increased adipose tissue, and it creates this vicious cycle and recurring cycle. We also have our psychological factors to take into consideration with these patient subgroup as well. Things like poor self-esteem, poor self-image, and then we have actual physical limitation. I touched base on how important sleep is for healthy parasympathetic nervous system. Things like sleep apnea, poor sleep quality, not having enough good, deep quality sleep, and then also having decreased mobility, decreased stamina, and just having all around just physical movement limitations due to excessive BMI or weight. So there's a lot of approaches. And I feel when I was working at the retail pharmacy, you typically see something like a PDE5 inhibitor or, Cialis, Viagra just getting thrown at patients with erectile dysfunction if they qualify. But there's not really a one size fits all. It's not always a blood flow problem. We have to take into consideration psychological and neurological concerns as well. And in some patients, it's important to take a multifaceted approach where you're addressing underlying psychological, neurological, and potentially even physiological concerns, right? And we can do that through a variety of different things. Typically, I like to start with lifestyle interventions, aerobic exercise. Are they getting dietary needs? Are they getting healthy amounts of sleep? On average, 7 to 9. But it honestly, with recent sleep studies and research that's going around the realm of sleep, it really depends on the individual on what they need for a healthy amount of sleep. Are they doing good stress management? Breathing exercise, meditation. Are they going for walks? Are they speaking to someone to get help if it's really to that extent? And then in patients where it is a physiological concern, blood flow, we can do things to help relax the, penile arteries and help provide blood flow. And then, if it's on the hormone spectrum, BHRT, bioidentical hormone replacement therapy, where testosterone supplementation may help improve decreased libido and other concerns as well. And it has other benefits as well in terms of energy, lean muscle mass, cardiovascular benefits as well. And, at times there might be a need to refer to a specialist like a psychologist or a therapist to resolve mental health concerns and help things like self-image or if there's past trauma that's leading to erectile dysfunction. These are all factors that sometimes can take place, but it's important to know when to refer out for a specialist with these patients as well. And if all else fails, we can also try doing combination medications. Like I said, there's not a one size fits all. Maybe a PDE5 inhibitor doesn't work. Let's try a couple of different options. So touching base a little bit more on what specific lifestyle modifications can we take to help improve sexual wellness and potentially even erectile function in patients experiencing erectile dysfunction, right? So currently, the World Health Organization recommends at least 150 minutes of moderate intensity physical activity per week, aerobic exercise, with muscle strength training activity 2 to 3 days per week. We can recommend things like diets, Mediterranean diet. It's filled with nuts, whole grains, fruits, dairy, olive oil, where it can help provide a nutrient-rich diet while also helping things like cardiovascular disease and blood flow concerns as well. We can help implement or recommend weight loss, working with a dietitian or working with a personal trainer and increasing movement in certain individuals if they're able to. There was a study done on men with BMIs of greater than 30 between the ages of 35 to 55 that showed a 10% loss of total body weight resulted in an increase in erectile function just through a 10% decrease in total body weight. Again, can't stress this enough. Having adequate, healthy sleep is also important. This helps reduce stress and cortisol, which will positively impact the desire pathway. Having cortisol and stress negatively impact the desire pathway. Elevated levels of stress may lead to things such as performance anxiety, other forms of sexual dysfunction out of just blood flow concerns. It's been shown to help reduce nitric oxide availability, which is needed for smooth muscle relaxation. Again, we want to be in a parasympathetic state for the initiation of any type of intercourse sexual encounter. Really helps kickstart that process. In terms of tobacco and excessive alcohol, I mean, it should be a no-brainer, but we want to encourage tobacco cessation. Tobacco has been shown to damage vascular systems. It's been shown to be a vasoconstrictor. Alcohol can also negatively impact cardiovascular health with the added negative of nervous system signaling. It can negatively impact that, which are all essential for arousal. And studies have shown for tobacco cessation that men typically see improvements within 3 months of quitting potentially. So, what is the rationale for compounded meds and where do compounding pharmacies kind of fall into place here? Right. So, what is the custom compounded bioidentical hormone replacement therapy rationale? It's customized for the patient's individual needs. We have topical options like creams and gels, where it's a great non-invasive approach that bypass first pass metabolism, and patients can just apply and go about their day. The caveat with this is we want to look at what amount systemically is the patient getting, which in case there might be other options that are better terms of oral capsules, we can do this for a variety of different BHRT. Typically, we see it with micronized progesterone in perimenopausal and menopausal women. And we want something to go through first pass metabolism, for example, progesterone, where it can be metabolized into allopregnanolone, where it can have sedation effects on the GABA A receptors to help these patients with sleep disturbances. We have options like troches and we have options like sublingual drops, which are great options if you're trying to limit enzymatic activity. The mouth has limited enzymatic activity as compared to the stomach, and you don't have to deal with the gastric pH. It's easily absorbed through the vascular system in the mouth through the thin epithelial layer. And then also we're able to bypass first pass metabolism for medications that we're concerned about hitting the liver hard. And then we have vaginal preparations. Vaginal preparations provide targeted therapy for conditions like GSM, genitourinary syndrome of menopause, where things like vaginal atrophy, dryness, painful intercourse are concerns for the patient. So on this slide, I did include a steroidogenesis pathway starting at pregnenolone. You could just treat cholesterol right above that, typically kicking off the steroid pathway. We've been getting a lot of questions about hormone precursors in the pharmacy in terms of BHRT therapy and sexual wellness. So I just wanted to touch base on it very briefly. Some of the questions we get are revolving around DHEA, which DHEA helps regulate the body's cortisol production, supports a balanced stress response and overall just hormone equilibrium. And we can see that DHEA is actually converted here to testosterone and estradiol as well. We also have a metabolite of DHEA called 7-keto-DHEA. It's a natural occurring metabolite of DHEA, which offers many of the same benefits without converting into estrogen or testosterone. And then we have pregnenolone at the top. Pregnenolone, I'm sure many of you have heard it as the master hormone or the mother hormone. Because of its broad influence on the endocrine system, pregnenolone is being converted into pretty much everything: progesterone, testosterone, estrogens. Because of its broad influence on the endocrine system, right? It is rarely used as a standalone option. Instead, it is typically compounded as a part of a more comprehensive hormone restorative plan to help with systemic balances and endogenous hormone production. It's typically where I see DHEA and pregnenolone in terms of being grouped into this, testosterone package, or basically providing the body with natural building blocks to provide and support its own endogenous production of hormones and androgens. So what are some other pharmacological opportunities we have outside of just these HRT, these hormone replacement therapy precursors? Things like oral PDE5 inhibitors, dopamine agonists, hormonal regimens, Peptides are becoming a huge topic on the market today and in the healthcare field. And then intracavernosal injections for our male patients if needed. So we do have things like PDE5 inhibitors, right? PDE5 inhibitors, phosphodiesterase type 5 inhibitors. It's our tried and true treatment for erectile dysfunction. It's typically what a lot of younger men or older men who are experiencing erectile dysfunction, unfortunately, and sometimes they work really well, get put on to just, here, take this, it'll fix your problem. Mechanistically, I'll briefly go over it, just maybe for some of us who might not be super familiar. But PDE5 inhibits an enzyme. It inhibits the PDE5 enzyme in endothelial cells, which prevents the breakdown of cyclic GMP, allowing the smooth muscle to relax and fill with blood. Typically seen being used in men, right? Sometimes seen off-label at lower doses for women as well to help promote blood flow to genital tissue. Now, for off-label usage and just from feedback from patients, it's a mix. It's a mix in terms of are they really seeing a benefit or not? Some say they do, some say they don't. So data is still up in the air, and I do think there's more data and more studies that need to be done on PDE5 inhibitors usage in women, but some do see an effect. For all of these medications that we're discussing today, it's important to keep in mind that this will not affect, there still needs to be some type of sexual stimuli. Some may impact libido and arousal. Something like a PDE5 inhibitor really won't impact libido. And there still needs to be some type of external sexual stimuli to get the process going. For PDE5 inhibitors, typically we see a time to onset of around 30 minutes, and then half-lives will vary with sildenafil, being, things like Viagra being short, and Cialis being longer, or the weekend warrior is what we call it in the pharmacy. And then potential side effects, maybe everyone isn't a great candidate for this. If they have CVD, cardiovascular disease that's uncontrolled, might not be a good candidate. Potential side effects like headache, flushing. Some patients get vision changes, muscle pain, even things that impact blood flow can lead to priapism, which we need to make sure our patients are aware of as well. For PDE5 inhibitors, it's also important to note that they really shouldn't be taking this with nitrates or like nitroglycerin, or guanylate cyclase stimulators like riociguat, due to the synergistic effect it has on hypotension, and you can risk severe hypotension. We also have apomorphine. So apomorphine it's a centrally acting dopamine D1 and D2 receptor agonist, which works to enhance arousal by stimulating hypothalamic and limbic pathways. So this is more working in the CNS. It's a great option for men and women who have, psychogenic or neurogenic related sexual dysfunction, where maybe blood flow isn't really the concern. It's working on that reward pathway. Time to onset is around 15 to 30 minutes. It can vary depending on the forms. Typically in the pharmacy, we see it as sublingual form, and some adverse effects that we need to be aware of, things like dizziness, nausea, headache. And again, it's important to note it does not trigger an erection. It can help with the erection response, but there still needs to be some type of external stimuli. We have our HRT replacement therapy, or hopefully BHRT, bioidentical hormone replacement therapy. Testosterone. So testosterone, great option for sexual wellness in patients who are experiencing decreased libido linked to andropause. And there's different forms of andropause, right? So decrease in testosterone can happen for a variety of different reasons: age, stress, medical conditions, lifestyle factors. I alluded to this earlier on previous slides, and I'm back into it now. Study from 2020. There is a study from 2020 that showed a decrease in mean total testosterone in men, starting at around 605 in 2000, and has decreased by 150 points in 2016, with no plateau in sight. It looked like a steady decrease. Now, this can be linked to a variety of different reasons, as I previously discussed: diet, lifestyle changes in the decades. But it is something to note, and it's also very concerning. Potential benefits for testosterone replacement therapy if the patient needs it: things like libido, sexual health, muscle mass, body composition changes, bone density, even improvements in energy level. We have a variety, at least in the compounding realm, a variety of different dosage forms, things like injections, things like liposomal, transdermal or topical, oral, sublingual. And these dosage forms will really impact frequency will really vary depending on the dosage form, where maybe you'll see a once to twice weekly for an injection, maybe daily for a topical or an oral option. And we do want to make sure patients are getting the appropriate labs. Make sure you're getting a baseline lab, making sure you're ruling out, is it primary andropause? Is it secondary andropause, where maybe we can start with something like enclomiphene instead of testosterone. And then doing follow-up labs, anywhere from 4 to 8 weeks, depending on what your clinic is comfortable with, and so on and so forth. What about our female patients, right? Hormone replacement therapy. Testosterone is not just for men, it can be given to women, but sometimes women who are going through perimenopause, who are in perimenopause or going through menopause, might need some additional support. An option for these patients are things like estriol or estradiol, E2 or E3. It's an option for sexual and wellness in patients who are experiencing decreased libido due to GSM symptoms, right? Genitourinary syndrome and menopause. Decreases in estrogen can happen for a variety of reasons, such as just biological age, stress, medical conditions, lifestyle factors. It's important to note that I also included DHEA here as well because of its importance in vaginal applications. DHEA has been shown to help local tissues produce its own estrogen as a precursor. There is a study out that shows, hey, if you're giving an estriol or estradiol vaginal application and you tack on DHEA with it, it decreases occurrence of things like UTI as compared to estriol alone over a 12-week period, while also enhancing local vaginal tissues, estriol or estrogen components as well. So what are the benefits? Things like improved libido, sexual health, reduced heart disease, depends on the systemic levels, improves sleep potentially, muscle mass and strength. So it can do a lot of different things, and you can get it in a lot of different forms, whether that's injection, transdermal, vaginal, and then oral as well, or sublingual. And again, dosing frequency is really going to vary depending on the route of administration. Things to keep in mind. Adverse effects. When you're doing something like a vaginal application where you're looking for targeted local therapy, there is less concern for systemic side effects. However, it still should be on our radar for those patients who may experience them. So, estrogen-related side effects, it can have an increase in vaginal discharge. Patients might report breast tenderness, headaches, potential water retention or abdominal swelling are all potential side effects. And for monitoring, we want to do the same monitoring that we do for all of our BHRT therapy. Make sure we're getting baseline, make sure we're doing follow-up labs, and then go from there. Bremelanotide. So now we're getting into our peptide regimens. So bremelanotide is also known as PT-141. You might see this term being used interchangeably between the two. Bremelanotide is a synthetic peptide that originally was developed from for melanocortin receptor research, right? So what they found was when they were testing it, that they also had a positive impact on desire and sexual wellness. Bremelanotide stimulates receptors in the brain and central nervous system, primarily the MC4R receptor, melanocortin type 4 receptor, but it can also target other melanocortin receptors, and we'll talk about why that's important here in a little bit. You know, it's in the MC4R receptor is important because it's involved in the arousal and sexual desire pathway. It's essentially we in the pharmacy realm we say it's like flipping the switch for desire, essentially. It's important to note that women who have hypoactive sexual desire disorder or a deficiency of sexual thoughts, feelings, receptiveness, stimulation that's been present for a fairly decent amount of time, bremelanotide has actually shown improvement with the addition of BHRT therapy, bioidentical hormone replacement therapy, in these patients. It was approved by the FDA in 2019 in premenopausal and maybe even postmenopausal women as well. Time to onset, it's really going to depend on the dosage forms in the Compounding world, we do see it as sublingual, nasal spray. We even see it as injections, and it can take, anywhere from 30 to 60 minutes. Injections might be a little bit quicker. Considerations, adverse effects, things like flushing, headache, tachycardia. Now, something to note, I unfortunately didn't include injections on here, but when it's given by injection, the bioavailability of this increases enough to where something called hyperpigmentation can potentially occur. This is because even though it primarily acts on the MC4R receptor, it can also act on other melanin receptors as well. So there can typically be limitations to things like frequency, so limiting it injections to once in a 24-hour period, and potentially even a certain amount of injections per month, for example, 8 times per month. So hyperpigmentation can potentially happen with any of these, but it's more notably noticed with the injection. So definitely something to keep our patients aware of. And if needed, and they're seeing hyperpigmentation, to discontinue immediately. Another peptide regimen, oxytocin. So many of us know this as the love hormone, fostering connections, intimacy. We know its medical usage in terms of lactation and childbirth and helping that mother-child bonding. Its benefits in the realm of sexual wellness. It can potentially help enhance libido by activating oxytocin receptors in the brain and spinal cord, and can help foster and strengthen those connections. You know, it's been shown to help potentially enhance arousal and satisfaction. In the compounding world, we see it as sublingual, nasal spray, even vaginal topical applications. Something interesting I found when doing deep dive on sexual wellness is in men, it's involved in potentially assisting or inducing that penile erection like pathway, sexual desire, and helping prevent or may potentially prevent premature ejaculation. We see actually elevated levels of oxytocin in men with hyperactive or hypersexual disorder as well, which I found very interesting. Um, which we can see why maybe potentially implementing it into men and women's medication regimen might help with sexual disorders as well. In women, we see it in vaginal creams to help, it can help promote normalization of the vaginal epithelium layer. Um, it can also potentially help with vaginal atrophy in postmenopausal women. And oxytocin specifically has shown to improve sexual satisfaction in these patient subgroups for women of the postmenopause age. Time to onset, roughly 30 minutes, can vary depending on the dosage form. And things we need to take into consideration and educate our patients on are things like headache, dizziness. It can potentially cause uterine contraction in postpartum women, and then nasal irritation as well. As we said, nasal spray is a dosage form for this. And then lastly, for our men, we have intracavernosal injections, things like Trimix and Bimix. So Trimix is alprostadil, papaverine, and phentolamine. Bimix it's a combination of papaverine and phentolamine. These are going to be intracavernosal injections, which are typically used with a subcutaneous, like an insulin syringe, for example, 29 to 31 gauge, half inch, or basically the smaller the better. Um, and what are they doing? So alprostadil and papaverine and phentolamine are all working to, in different ways, dilate blood vessels, relax smooth muscle to get the blood flowing in the penis, essentially. For how it's typically recommended, because we don't see this, there's some offices that are new to it and some clinicians that are new to it. It is a 90-degree injection at the 10 o'clock and 2 o'clock position on the top of the penis, and to avoid hitting the urethra. And you want to do it on the 2/3 part or closer, emphasis or closer part to the body or trunk. The reason why we want to do that is is because the tip, has a lot of nerve endings on it, and there can be increased pain, increased fibrosis in that area if you do it at the tip. May not work as well. It does not contain the same amount of corpus cavernosum tissue as the shaft does, or aka the smooth muscle and vascular endothelial layers. Things that we need to counsel patients on. Things like fibrosis, hey, you are doing a penile injection, so consistent use can lead to scar tissue formation. Things like headaches, dizziness, hypotension. Um, and then, because it's doing vasodilation, priapism is often counseled on as well, where an erection is lasting longer than 4 hours, right? Go to your nearest ER or hospital to get follow up with. Now, this is more so I see this in terms of therapy as a last line for men with for sexual wellness and erectile dysfunction, purely because it's an injection into the penis. And typically it's used if PD5 inhibitors aren't working, you've tried your bremelanotide, your oxytocin, and just nothing seems to be quite working. What I will say to that is when it does work, it works really well, and we have patients who rave about it. So there is a place in therapy for this. Supplements for sexual wellness. So I'll briefly go over a few of these. So for our male patients who are looking for a more natural way to help with sexual wellness and erectile dysfunction, we have things like Fidogia, which will help boost natural testosterone production. Tongat supports energy and libido and stamina. We have things like Shilajit, which is going to be used for men and for reproductive health. Zinc and boron are just all around good building blocks for androgens in males. And then an L-arginine, which helps improve blood flow. For our female patients, couple of similar ones, couple of different ones in here. We have ashwagandha to help reduce cortisol and help support stress reduction. We have fenugreek, which may help balance testosterone and estrogen levels. We have tribulus, which helps support vitality and sexual function. And then again, zinc. Zinc is an essential mineral for hormone health and hormone production as a building block. So, sexual health is not a luxury. It is an integral part of overall well-being, reflecting our physical, emotional, and relational vitality. With that being said, and after reviewing sexual dysfunction, let's start having these difficult conversations with patients and addressing root causes of sexual dysfunction with our patients. I did go ahead and include this slide as well with current Strive locations in case you are wanting to learn more or are curious, and then my reference slides as well. Any questions?
Thank you. This was wonderful. One question. So the beginning, you were running through like all of the various causes, and they can, it seems like they can range from physical, psychological. Like, how would you recommend for clinicians, to kind of start evaluating somebody to really understand like what it is that might be causing the issues, and then depending on what it is, like which treatments you would recommend since there's so many different options.
Yeah, absolutely. So I think starting that conversation typically is the hardest part. I don't think a lot of patients, I mean, maybe older patients are, but maybe younger patients aren't really probably going in and saying, hey, I'm having erectile dysfunction. I think, having things like pamphlets or trifolds available where a patient can reach and grab and start, asking about it is great. In terms of evaluating the underlying causes, once that engagement and that interaction starts to occur, you can start asking, hey, what kind of lifestyle things are you doing? Are you using recreational drug use? Are you an avid smoker? Excessive alcohol usage? Is there any, thing that could be leading to, blood flow concerns? Or do they have diabetes? Do they have, some type of over obesity, cardiovascular disease concerns, right? Where maybe a PD5 inhibitor, and if blood flow really is the concern, that might be a good step. Alternatively, if they have underlying psychological concerns due to past trauma, due to stress, anxiety, and sometimes these questions do get asked as well on a clinician level, depending on what the visit is for, right? Maybe at a baseline, they're asking that just to evaluate the patient, see how they're doing. And if there are flags or markers for concern in terms of mental health or mental emotional health, right? Then maybe we can start asking those, deeper questions of like, hey, was there anything that could have negatively, are you extremely stressed right now? Because stress can play in a role. Is your relationship healthy? Or, there can be underlying psychological concerns. So starting to ask those questions as well, but doing those markers prior or at your initial evaluation might be really important, where we can start evaluating and say, hey, young, healthy male, really seem stressed out or might have some, neurological concern, let's try maybe oxytocin, if it's a intimacy bonding concern. Maybe let's try bremelanotide if it's a arousal concern where they're just like don't feel like they're ever in the mood to do it. Let's check their hormones, let's see if there's a dip in hormones because of the decline of these past couple of decades. So it's really just asking those almost like those screening questions is how I would compare it or phrase it.
And then actually speaking of hormones, do you does Strive offer injectable testosterone specifically for women?
So yeah, so we do have a injectable testosterone. It's 200 milligrams per ml testosterone cypionate and MCT oil. It's a little bit less viscous. You can dose it, but then you start getting really small doses. At
Mhm.
this time, we at one point did have a 25 milligram that we since discontinued. We actually just rolled out a oral liposomal tablet, which we are recommending for our male and female patients that come in 500 micrograms. And we're seeing a lot of promising results with these liposomals in terms of daily testosterone supplementation and patients getting back on track for HRT therapy.
And today we've talked a ton about GLP-1s. If if there are patients that are on GLP-1s, is there any of these treatments that people should that might be better or worse for them to be on?
Yeah, absolutely. So I think it ultimately depends on the underlying physiological concern. If if we're talking about drug interactions, there would be, at least from the ones I discussed today, there's no direct drug-drug interactions between these medications with the GLP-1s. GLP-1s are generally very well tolerated medications due to some GI side effects and some other ones that we're finding. But in terms of, which one best should be used, with diabetes, typically vascular issues are the concern. So maybe like something like Trimix or a PDE5 inhibitor, um, or even if it's, decrease in androgens, then we can start going towards that hormone replacement route where maybe we do enclomiphene or testosterone. So it really just depends. And then if it's a mental concern, right, or a mental block, that's when I would start looking towards oxytocin or bremelanotide.
Oh, one second. Sorry. Okay. And then one more question. What medications do you recommend to stop conversion of testosterone into estrogen for men?
Yeah, so we do have aromatase inhibitors that can help block that if you're looking for more natural, um, if you're looking for a more natural approach, zinc 25 milligrams at bedtime can sometimes work as a natural aromatase inhibitor as well in these patients. But we do have aromatase inhibitors. Typically, you know, if it really depends on the excessive amounts of estrogen, right? If a male patient, for example, is presenting with elevated levels of estrogen, so breast tenderness, abdominal water retention, headache, moods, feeling a little moodier, right? Emotional, then maybe at that point, yeah, let's start, tackling on aromatase inhibitor because those have their own side effects associated with them, right? And limitations. So for those patients, who might have elevated estrogen levels, who might not be presenting with estrogen-related side effects, typically I would say, hey, let's hold off until some of those are starting to present, but we do have those available.
Well, that's great. Well, thank you so much for joining us today. We appreciate it. We've had a couple questions throughout the day. We are recording everything. We will be sharing out all these presentations with everybody afterwards. So with that, we're going to give everybody a quick 10-minute break. I know everyone's been sitting, so you probably need to